This is Module 6, Corrective Strategies and Closing the Loop. The information in this presentation is largely based on the Guidelines for Trauma Quality Improvement Programs from the World Health Organization 2009. You can see the web link there for more information. The core learning objectives in this module are to provide a basic understanding of the following: guidelines, pathways, and protocols for corrective strategies, targeted education as part of corrective strategies, improvement for specific providers as part of corrective strategies, improvement of resources, facilities, or communication as part of corrective strategies, how to close the loop, and a summary and conclusions. An essential foundation of a successful QI program is the development and institution of corrective strategies to address the problems identified and to evaluate and document the effectiveness of these strategies. These strategies include improved guidelines, pathways, and protocols, targeted education, improvement for specific providers, improved resources, facilities, or communications. Let's talk about guidelines, pathways, and protocols for corrective strategies. Guidelines are defined as systematically developed consensus statements that are designed to assist in clinical decision-making and that usually focus on diagnostic and treatment. Guidelines are usually general in nature and often rated by the power of the evidence. Guidelines are commonly developed by societies for surgical, trauma and critical care, emergency medicine, and other disciplines, with the goal of education and dispersing knowledge on the subject of appropriate care. Published practice guidelines provide evidence-based documents from which institution-specific pathways and protocols can be developed. Pathways and protocols expand on practice guidelines and are used as bedside instruments to influence care. The goal of both pathways and protocols is to decrease treatment variation in clinical management. Protocols are often institution-specific and consist of a step-by-step delineation of procedures for solving a problem or accomplishing a desired outcome. Protocols are often displayed in an algorithm format. A pathway implies continuous data collection and monitoring. Protocols may or may not include a continuous monitoring and data evaluation component. An example of a protocol specific to trauma would be a massive transfusion protocol. To decrease the variability in the ratio of red blood cells transfused to the volume of clotting factors transfused, a massive transfusion protocol can be designed on the basis of existing data regarding best practices and is used as a bedside tool to guide blood product administration in hemorrhaging patients. Targeted education is part of corrective strategies. Targeted education is used to introduce new or modify existing procedures for both diagnosis and treatment. Educational opportunities include existing methods such as daily ward rounds, departmental ground rounds, regularly scheduled conferences and case presentations. Other less routine but excellent educational opportunities include periodic journal clubs to highlight and openly discuss influential and controversial publications, as well as focused reading groups on specific topics of interest. Alternative educational opportunities include newsletters, posters, and videos from professional societies and health ministries. Many of these types of educational materials do not require the physical presence of a practitioner in a scheduled meeting and therefore can be accessed by the clinician when convenient. This is a good time to take a few minutes to think of some examples of how targeted education could be provided, like case presentations and newsletters. Existing methods for educational opportunities include daily ward rounds, departmental ground rounds, regularly scheduled conferences, case presentations. Less routine opportunities, periodic journal clubs to highlight and openly discuss influential publications, focused reading groups on specific topics of interest, alternative educational opportunities like newsletters, posters, and videos from professional societies and health ministries. An example of a targeted educational effort that might be identified by the QI process follows. By evaluating recent trauma deaths, the QI process may reveal that a problem exists with regard to patients with pelvic fractures. A number of patient deaths secondary to pelvic fractures and associated pelvic hemorrhage might be discovered as part of the QI technique of preventable death panel reviews. So if the QI process has now identified a problem, what is a possible corrective strategy to fix this problem? A method that potentially decreases mortality secondary to hemorrhage from pelvic fractures is early external reduction and stabilization of the fracture in the emergency department. A simple, easily available, and cost-effective method for initial pelvic stabilization is pelvic binding or sheeting. Although the concept of pelvic sheeting is relatively simple and cheap, the actual specifics of where and how to apply the binding sheet effectively can be best relayed to clinicians through a targeted session of education. The targeted educational session should include direct hands-on practice of the technical aspects of how to apply pelvic binding in patients with a pelvic fracture. Additionally, an essential component of this type of targeted educational experience is a thorough discussion, which should include a question and answer component on the indications and explanation of the small tricks that make application of the binding sheet more effective in optimally reducing fracture, the length of the binding, the advantages and disadvantages of using the technique of sheeting in patients with pelvic fractures. It is often useful to hold joint educational conferences with other services that are closely involved in caring for trauma patients. Regularly scheduled combined teaching conferences can discuss evidence-based guidelines, difficult cases, and other relevant topics. Such teaching conferences can involve 2 or more services such as general surgery, emergency medicine, anesthesiology, orthopedics, neurosurgery, and others. These conferences can be a valuable means of disseminating knowledge and can serve as a platform for establishing friendly relations while not in the stressful circumstances that often surround a critically injured patient. Think of some examples of the benefits provided by holding conferences as part of your educational process. Conferences can accomplish the following: to provide a forum for providing feedback on outcomes, both good and bad, to practitioners who had an important responsibility for patient care at a particular point in time, but who do not continue to care for a patient through the course of hospitalization. Provide a non-stress environment. Can build positive relationships when a particular practitioner's contribution to the care of the patient is publicly acknowledged and appreciation is expressed. Openly acknowledging the success of an educational context, which also makes frank discussions about poor outcomes more likely to be constructive. Some trauma centers find that holding periodic journal clubs in conjunction with other specialties at a location away from the hospital provides a friendly and non-threatening opportunity for clinicians to interact without the constant clinical demands of the hospital setting. Even if held infrequently, perhaps quarterly or twice a year, these educational opportunities can have a significant and durable positive impact by providing communication, interaction between clinicians, and ultimately, quality of care. Improvement for specific providers as part of corrective strategies. Most corrective strategies address system issues, but on occasion, they address the actions of a specific provider. This may be due to particularly problematic issues or because of a pattern of unacceptable performance. This area is a relatively small component of QI. It is important to emphasize that corrective strategies aimed at specific practitioners should be constructive. Although most corrective strategies identified in the QI process address systems issues, there are occasions when the actions of a specific provider must be addressed. Corrective strategies for individual providers include counseling, further training, and when all else fails, a change in privileges or credentials. Counseling can be relevant for doctors, nurses, and other staff when behavioral issues pose a problem. Counseling can be performed by the chief of the hospital or by the head of a department for doctors or by nurse manager for nursing staff. Counseling should occur in a timely fashion after any incident that merits intervention. Discussions are best held in private or in small groups if more than one individual is involved. Counseling can be very difficult, but at times it is necessary. Discussions should be documented and followed up. Bearing in mind standard behavioral theory, any positive responses or reactions as a result of counseling should be acknowledged and rewarded in order to optimize the effectiveness of the process and to reinforce positive behavior patterns. At times, further training is a useful corrective strategy. If technical issues in clinical care arise, providers can be referred to highly specific and intensive courses that emphasize clinical management. Further training may include behavioral improvement, such as conflict resolution training for staff who exhibit negative interactions under stressful conditions. When efforts to effect positive change in a particular provider through counseling or further training are not successful, on rare occasions, a change in privileges or possible dismissal from practice at the hospital must be undertaken. Such extremes are unusual corrective strategies and require implementation to high levels within the hospital, such as the medical staff office as well as department head. Restriction of privileges or dismissal from patient care should be reserved for occasions when other corrective action plans have failed. The potential for dismissal from practice at an institution or for restricting or denying privileges underscores the need for integrating trauma QI with hospital QI processes. The potential for dismissal also emphasizes the importance of documenting any prior corrective strategies and efforts implemented to improve performance in order to avoid controversy. Improvement of resources, facilities, or communications as part of corrective strategies. On occasion, a critical shortage or deficiency in resources repeatedly interferes with the process of caring for a patient. The deficiency may be improved through organization and planning without the need for high-cost solutions. One example is to make sure that resources necessary for emergency situations are readily accessible. This may in turn imply activities such as making sure that chest tube stocks are checked daily to ensure adequate availability when urgently needed, developing a difficult airway cart with multiple advanced options for obtaining an emergency airway, or designating a surgical airway tray that is always available should other means of securing an airway fail. Communication issues can often be resolved with simple solutions. For example, making sure that all staff wear large printed name badges can improve communications in a chaotic trauma resuscitation area or casualty ward. Providing designated cell phones for staff on call can solve delays in communications. Access to the operating room for emergencies can be improved by providing direct cell phones to be carried by the on-call operating theater charge nurse and anesthesiologist. The example of the QI program in Konkan, Thailand demonstrated that delays in care of the injured could be improved by a network of radios within the hospital. How to close the loop. QI must demonstrate that the corrective actions have had the intended effect. Closing the loop implies that the process or outcome has been measured after implementation of the corrective strategy and that improvement has been demonstrated. Some loops may never be completely closed, but may require ongoing monitoring and efforts to continually improve problems. A trauma QI process might identify an area for improvement in timely access and administration of blood products to patients. If a hospital or region has a blood bank available, a standardized communication process for obtaining blood products might be instituted as a corrective strategy. The creation or updating of this communication protocol with the blood bank would be an example of loop closure. However, this type of loop closure would require ongoing monitoring every time the protocol was activated to ensure that the process for obtaining blood products in a timely fashion continued to meet the needs of the patient and the practitioners. This is a good time to briefly review the handout on examples of loop closure. In summary and conclusion, an essential foundation of a successful QI program is to develop and institute corrective strategies to address the problem identified, and then to evaluate and document the effectiveness of these strategies. Corrective strategies are part of an essential foundation of a successful QI program, but they must be demonstrated to have the intended effect. Closing the loop implies that the process or outcome has been measured after implementation of a corrective strategy and that improvement has been demonstrated. There are a number of excellent resources available regarding this topic. Please feel free to access these for more information. Some examples of corrective strategies and closing the loop. Reviewing the printouts of this presentation. In teams, you can discuss and create lists of examples of corrective strategies that have been implemented in your workplace or identify areas where corrective strategies might be effective. corrective strategies including guidelines, pathways, and protocols, targeted education, improvement for specific providers, and resource facilities or communications. Thank you.